us a little bit about your research and what your main findings were.
So this project took place in Republic of Guinea, which has a total population of 12.7 million people, but only 5 practicing neurologists. It was carried out in Ignestine Hospital in Conakry, which serves a population of 1.7 million from both rural and urban areas. We recruited 97 children with highly active epilepsy and performed a mobile accessible EEG technology and compared it to a standard Exeltech standard EEG that would be available in our clinics to see what the sensitivity of this mobile technology would be in comparison to the quote-unquote gold standard that's available at present. So the mean age of the children we enrolled was 10, and their age of first seizure onset was about 4, and they got the diagnosis on average age of 6 years of age. What was a bit worrying was a third of them weren't on any medications. 25% of them had had a seizure over 5 minutes in the past 12 months. 10% of them had had burns, and 20% of them had had head traumas. So what we found was that the mobile EEG system was moderately sensitive, at about 50% for epileptiform abnormalities, but highly specific, so over 90%. So that means if an abnormality was found, it was likely to be real. So this is important implications in the clinic, because these people pay out of pocket for any either neuroinvestigations, outpatient clinics, and also medications. So we were able to train local healthcare workers with just 2 hours of training to apply the technology with their flexible EEG impregnated head caps. All they have to do is do one measurement of the head circumference, and the data is transmitted wirelessly to an Android tablet and then applied. And then the EEGs are read remotely by specialists, in our case in the US and Canada, via a secure platform which was designed for the purpose.
Great. So rather than have to get a full EEG with all of the leads, this is just
so it's a 14-channel headset,
okay.
And we're slightly restricted in that because the digital amplifier, usually the standard is 21. The digital amplifier can only cope with that much data, and actually that's one of our future directions. We're trying to work with our collaborators in Denmark to increase the capacity of that digital amplifier. So it's that's why we have a slightly reduced sensitivity in comparison to the standard EEG.
So you're taking these kids with epilepsy who really have very little in the way of resources or support.
Yeah, none of them had ever had an EEG before. 20% of them had had CT. And only, as I said, a third of them weren't on any medications whatsoever.
Right.
Yeah.
So based on the results of your findings, or based on what you guys found, do you think that will help improve the care of these kids with epilepsy?
It's important because we taught local healthcare workers, like the EEGs, the portable EEGs were applied by the neurology trainees or local healthcare workers, and then the data was transmitted remotely. And another positive is that it's wireless. It doesn't require electricity, which in these situations can sometimes be unreliable or not present. And I think it will. So what we did was we looked back at, if we only had the mobile EEG, would it have potentially have changed management? And we found 9 cases, so that's roughly 10% of the cohort with a generalised abnormality. 6 of them were on phenobarbital, 1 of them wasn't on any medication, and 1 of them was on carbamazepine. So it may have, and 1 of them was on valproate, but it may have actually changed the clinician's maybe choice of AED or anti-epileptic medication in those situations.